high-dose methotrexate in osteosarcoma. We're going to talk about high-dose methotrexate in osteosarcoma. So a lot of us often debated within departments as to whether we really need the high-dose methotrexate. Can we do away with it because it's not very easy to give? We have to give it as an inpatient. We have to monitor levels that may or may not be accessible to all of us at all times. So let us hear from our two experts today about whether we should really be using methotrexate in osteosarcoma. So for this debate, I invite, on behalf of Dr. Girish, who will join us very shortly and moderate the rest of the session, I invite Dr. Ricky John, professor in pediatric hemonc at CMC Vellore, and Dr. Jyoti, who's assistant professor in pediatric hematology oncology at St. John's Medical College, Bangalore. So Dr. Ricky will be speaking for the topic, so for the use of high-dose methotrexate, and Dr. Jyoti will be speaking against the topic. I invite Dr. Ricky first to speak for the first session for 20 minutes, followed by Dr. Jyoti's perspective for 20 minutes, and then we will allow time for rebuttal and discussion. So hopefully by then, Dr. Girish has joined us and will be able to more expertly moderate the session compared to me. All right, Dr. Ricky, over to you. Welcome once again, and we look forward to hearing from you.
Thank you, Dr. Vandana. Okay, I will. So you have my slides, or do I have to put it up from here?
Please put it up if you do. That would be good.
Okay, because he asked me for it, and I thought he was going to put it. Just hold on now. Okay, not sure how to do this. Why is that not working? Are you able to see my screen? Yeah.
Yes, we can. It's on the last slide, actually, so you may have to scroll up and then slideshow.
Okay, I have to apologize because in the morning while I was sending this, I have somehow managed to, I deleted my whole slides and I just put together my thoughts as it was in the previous slides. So my slides might be a bit hodgepodge, but I will need it just for SQ. Thank you for inviting me, Dr. Preetham, and thank you for being here, Dr. Vandana, and welcome to my opponent, Dr. Jyoti, and to everybody who is here. Let me start. High-dose methotrexate in osteosarcoma. As we all know, osteosarcoma is the most common malignant primary bone tumor that we see in children and adolescents. And with the introduction of chemotherapy, prognosis has markedly changed for these two. And in like 1987 and 86, two randomized controlled trials came out confirming the favorable impact of chemotherapy on this disease. And so that was what was one of the studies there, and that will show you how much improvement there has been in the chemotherapy compared to the before that, when only amputation was being done. Now, both the studies used a lot of multi-chemotherapy, which included high-dose methotrexate, but it also included doxorubicin, cisplatin, bleomycin, cyclophosphamide, and actinomycin. But it did have the desired effect of increasing the overall event-free survival. From then, we have gone through sequential trials, and currently most of the drugs that we most frequently use are high-dose methotrexate, adriamycin, cisplatin, IFOS, and ETOP for this problem. I agree that there has been no study that is, says that high-dose methotrexate is absolutely mandatory for treatment of osteosarcoma. There has been no randomized trial that has been done comparing high-dose methotrexate with any of the currently used modern non-methotrexate-based protocols. But methotrexate per se has been found to be quite efficacious prior to this itself. So from the 70s, people started using methotrexate here and there. There were several smaller trials, case reports and things. And when they put all these small trials together, we mainly at that point in time, they were using it for advanced diseases or relapsed diseases. And they found that there was a very objective response to the high-dose methotrexate, about 26% of response, so 10 out of the 39 patients that they had. Rosen et al. Also at the similar time found that the histologic evaluation at the time of surgery after having given neoadjuvant chemotherapy with high-dose methotrexate, he found that we could actually prognosticate by using this tumor necrosis. And he also found that almost 78% of the patients who received high-dose methotrexate showed tumor necrosis of more than 50%. So high-dose methotrexate, even as a single agent, has shown to be very efficacious. Yeah. Then Aniga et al. Did this nice systematic review where they analyzed a whole lot of single agent phase studies. And he looked at all the drugs that were being used and looked at the response rates of these. And here we find that the 4 drugs that we do have, the adriamycin, IFOS, methotrexate, and cisplatin, all have fairly decent response rate. As you can see, Doxo has 43, IFOS and methotrexate around similar 33 and 32, and cisplat at 26. Etoposide, however, has not been shown to be efficacious at all, meaning it's only 4, very low response rate. Then they also looked at this neoadjuvant studies. They looked at 19 of them, and they looked to did a meta-analysis and looked to see the overall survival and the event-free survival. So what they found was that those regimes which had 3 or more drugs included in the regime did far better than the 2-drug regime groups. So if you see the 5-year event-free survival, 48 versus 58, and the overall survival also significantly better. However, just to say that most of the 3-drug regimes and 4-drug regimes that were being used at that point included methotrexate, high-dose methotrexate, and adriamycin, cisplat, plus minus ifosfamide, most of them. So current treatment, after this study, so current treatment protocols do have 3 drugs or more. And the way things have gone, chemotherapy is currently, at least in the high-income countries, are considered the standard of care. So to say why methotrexate, it has adequate proof of efficacy and is fairly well tolerated. If you take out methotrexate, what do we have left? This is a study that was done by Isakov et al. And you can just see how many of the drugs that they have tried, all with very sad responses, really, either no responses or just, a little bit here and there. So if you were to take out high-dose methotrexate, you will have to have a regime which contains a high dose, which contains ifosfamide. Okay, so if you look at ifosfamide, this is a phase 2 study that was done quite some time back by Lee Daly et al. Basically, they used ifosfamide in newly diagnosed osteosarcoma with metastatic disease or unresectable disease, and also in one group where there was recurrence, but they had not been exposed to ifosfamide prior to this. And this group received a per cycle of 12 grams, so that's a decent amount of ifosfamide there. And they found that in the two groups, what they found was that there was a good response, but those who had not been, like the relapsed cases who had been treated and then come, even though they hadn't been exposed to ifosfamide before, they didn't do as well as the naive to treatment ones. Then there were several other smaller studies. Myers et al. Is one where they were actually trying to study muramyl tripeptide. So they had two big groups with MAP on one side and MAP IFOS on the other. And in each of these groups, they then randomized to with MTP or without. And they used a lesser dose of ifosfamide, and they found that there was no difference either in the necrosis or in the event-free survival in these two groups. Okay, the group that they did find some difference was the group with MAP IFOS with MTP, but other than that, there wasn't very significant difference in the two main groups. Bassi et al. Had a similar study. He used slightly, intraarterial cisplatin and intravenous cisplatin. That was his thing, but otherwise it was similar to the previous study with high-dose methotrexate, adriamycin, and on one side, high-dose methotrexate and adriamycin with IFOS on the other side. And that further divided to get intraarterial cisplatin or intravenous cisplatin in the two groups. What he found was those who were on that 4 drugs, so that's the IFOS side group, did much better compared to the 3-drug group. Yeah, so otherwise there was not much difference in the two groups in that as well. Then there was another study by this Palmerini et al. She's found a very good action of ifosfamide, which she's given in high dose. It's 15 grams per cycle. That's 3 grams per day into 5 days. And she found that the overall response rate was like 20%. So the median event-free survival was 6 months, and an overall survival at 1 year was like 62. Sorry, this was done in relapsed patients. Yes, it's written there. Okay, so it was found to be very efficacious, and I remember this is in the relapsed setting. But she also found that toxicity was quite significant. So in that Aniganet response rate thing, IFOS comes at 33%, so it's a good drug. High dose IFOS probably works better than lower dose IFOS, but it looks like it has higher toxicity. With MAP, I mean, that is ifosfamide with MAP, some studies do show that the outcomes are even better than with just MAP. And there are some studies that are suggesting that we use MAP with IFOS maybe as an upfront regime as straight away. Of course, we have to remember that the Euromus one showed that MAP-IE made no difference in the 2 arms that they did for the high-risk osteosarcomas. And also remember that the toxicity was more in this people who use the high dose ifosfamide. So coming to the question today, high dose methotrexate, do we really need it? I would say yes. It doesn't, giving the profile that we have, it doesn't really make much sense to remove high dose methotrexate from our first line treatment. And I suppose I would agree that yes, you would need a RCT to really compare the other protocols we have with or without high dose methotrexate and see. But, we really can't afford to really lose it, because at least in the relapsed time, we will need to use high dose methotrexate. So if you've given an IFOS based regime upfront, when they relapse, and we know that quite a few of them do relapse, we will have to use high dose methotrexate as one of the options in that case. So that's all I have to say for now. Thank you.
Thank you, Dr. Ricky, for putting your perspective. Probably we can now call up Dr. Girish, who has joined. So, sir, any comment from your side before we proceed to the other opponent of this debate?
Good evening, everybody. And first of all, sorry I was about 10 minutes late because of a previous meeting which overran. I think Ricky has very eloquently put together where we stand with methotrexate, and also the uncertainties which are there with using methotrexate or ifosfamide. So I think let us wait for Jyoti to present first, and then we can open up the discussion and take it further.
Hello, everyone.
Just a moment, Jyoti.
Yeah.
Could you stop sharing your slides, Dr. Ricky, please?
Yes.
Thank you. Yes. Okay. Over to you, Jyoti.
So, am I audible? Ma'am, am
Yes,
I audible?
Clearly.
Yeah.
Yes. Yes.
Yeah, I'll just share my screen. I just need a minute. Is my screen visible?
Yeah, it is visible.
Yeah. So I have 20 minutes to present my argument. So thank you. Thanks to the organizers for this opportunity, and thanks Dr. Ricky for that presentation and opening the discussion. So I will move ahead with my presentation and place my acknowledgement subsequently. And the layout of my presentation will be as follows. So the 4 important chemotherapeutic agents in osteosarcoma, as Dr. Ricky mentioned, are adriamycin, ifosfamide, methotrexate, and cisplatin. So the currently accepted formula for treating osteosarcoma is a dyad backbone of cisplatin and doxorubicin with addition of either high-dose methotrexate or ifosfamide. As of now, specifically in the Western world, MAP, which is a methotrexate-based 3-drug regimen, is the standard of care in osteosarcoma. And alternative regimens are not relevant for Western countries, are not even a priority for ongoing research. So if I appear to have mistaken what my topic is, you are mistaken, and I will present my argument based on all the aspects that one would look into before choosing a regimen that is appropriate for the center that they work in and the resources that are available within their centers. And these aspects would be, is the regimen an acceptable standard of care? Is the regimen feasible? What is the toxicity of the regimen we are trying to use? What are the supportive care demands of such a regimen, and is it economically viable? So this will form the layout of my presentation. So to begin with, what are the regimens that can be accepted as standard of care? Firstly, let's look into how methotrexate, adriamycin, and platinum-based regimen became the standard of care. So I look into the history of methotrexate-based regimens. And basically, what we see in the history of evolution of treatment of osteosarcoma is that A used methotrexate and therefore B adopted it. B used it and therefore C adopted it. And because C used it, it is the standard of care. For example, Norman Jaffe described the role of the efficacy of high-dose methotrexate in treating osteosarcoma in 1970. Thereafter, Rosen et al. From MSKCC used high-dose methotrexate with 2 other agents in their T4 trial. Around at the same time, the multi-institutional osteosarcoma study, which is a landmark study that proved the value of adjuvant chemotherapy in osteosarcoma, also used high-dose methotrexate with several other agents to prove the superiority of chemotherapy. Subsequently, all the trials performed at MSKCC, that is the T series of trials, have all used high-dose methotrexate in their chemotherapeutic regimens. And MSKCC and the trials by MSKCC were instrumental in influencing the choice of drugs used by centers across Europe and America in their subsequent trials. And likewise, CCG and POG also used the same drugs that were used in the T10 protocol specifically, which is adriamycin, methotrexate, and platinum, along with BCD, to achieve survival rates of close to 60%. The CCG and POG then join hands to form the COG and conduct the first intergroup trial 0133. And what we see in this trial is that they use the same drugs again, high-dose methotrexate, cisplatin, and doxorubicin. Compare this three-drug regimen with a 4-drug regimen and declare that the 3 drugs are equivalent to the 4-drug regimen. The same 3 drugs, that is methotrexate, adriamycin, and platinum, which was part of the COG's INTO 133 trial, was again part of the EUROMAS-1 trial, which is the largest RCT till date, and achieved an event-free survival of 60% and OS of 76%. Why was the same protocol again used by COG? Because COG was the founding member of the EUROMAS trial, and it collaborated with COSS, SSG, and EOI, all of which had experience with high-dose methotrexate, except EOI, which had a preference for adriamycin and platinum-based 2-drug backbone. So while the EUROMAS trial was being conducted, Norman Jaffe declares that high-dose methotrexate is a superior drug in the treatment of osteosarcoma. And in his paper, he also goes on to state that a non-methotrexate-based regimen is actually a major poor prognostic factor. And where does this statement come from? It is based on this paper, which compared just 356 patients who received methotrexate with a very small number, that is 64 patients which did not receive methotrexate and used another alternative protocol, and looked at their metastasis-free survival to declare that it was a poor prognostic factor for osteosarcoma. And soon after the completion of the EUROMAS recruitment, Isaacoff and Gorlick go on to state that methotrexate, adriamycin, and platinum-based therapy is the most effective regimen in the treatment of osteosarcoma. So through this journey, we clearly understand that the benefit of high-dose methotrexate is an unquestionable fact. However, the benefit of high-dose methotrexate over a non-high-dose methotrexate regimen is a questionable fact. So what are the alternative regimens, and what were these alternative regimens doing all this while when high-dose methotrexate was being celebrated as the treatment of choice for osteosarcoma? So to answer that question, I present this very same slide, which was presented by Dr. Ricky in her presentation. This is a slide from Aninga et al.'s meta-analysis, where the 4 important drugs used in osteosarcoma were compared. And what do we find? Adriamycin, used as a single agent, has a response rate of 43% and is the most important drug, followed by ifosfamide and methotrexate, which incidentally have the same response rates, which is at 32 and 33%, followed by cisplatin. Despite ifosfamide being as good as methotrexate in osteosarcoma, why was a methotrexate-based regimen so celebrated as compared to an ifosfamide-based regimen? The answer to that question I will give with the following arguments. Firstly, while adriamycin and high-dose methotrexate were used in osteosarcoma in 1960 and 1970 for the first time, the role of single-agent ifosfamide was discovered almost 15 to 25 years later in 1985. And it was only in 1991 that ifosfamide was used as part of a clinical trial for the first time. So this I call the first mover advantage. All of the trials conducted in North America and Europe by then had enormous experience with the usage of high-dose methotrexate. They almost had close to 2 decades of experience with high-dose methotrexate before the use of ifosfamide. And this vast experience provided a certainty and reliability for the use of high-dose methotrexate. However, the supremacy of high-dose methotrexate over a non-high-dose methotrexate containing regimen still remains a question. So to look at the history of non-high-dose methotrexate-based regimens, I'd like to showcase this slide where all the study groups that performed studies in the chemotherapy of osteosarcoma. And all of these study groups in both the American and European continent actually used only high-dose methotrexate. Among all these study groups, there were only 3 study groups which tried using a non-high-dose methotrexate-based regimen, producing only 6 studies, of which only 2 were RCTs. So what do we make of the data and relevance of these studies? So whenever we have a controversy, we look into answers from an RCT. And since there are almost no or few head-to-head RCTs containing these 2 regimens, we will look at meta-analysis, the first of which was presented by Aninga et al. In 2011. What he looked at was the 6 studies presented by the study groups I just mentioned. So the EORTC conducted 3 trials, and the SWOG and Brazilian groups conducted another 3 trials. So we only have 6 trials trying to provide evidence for the use of non-high-dose methotrexate regimens. So this again is a comparison of 6 studies versus these enormous number of studies. And what did Aninga find? He found that the outcomes of these 6 trials was around 40 to 55% versus 60 to 70%. So how do we interpret this? The decrease in, the lower outcomes that were seen with a non-high-dose methotrexate regimen as compared to a methotrexate-based regimen were probably because of these aspects. Firstly, these were the first or early trials conducted on a non-high-dose methotrexate-based regimen, and they were being compared with the results of later trials in high-dose methotrexate, which almost had 2 decades of experience. Also, the dose intensity of drugs used in the non-high-dose methotrexate regimens were found to be suboptimal. Carboplatinum was used in certain trials as against using cisplatinum. The EORTC often used 2 drugs in their trials as compared to 3 drugs, which is now standard of care. And the heterogeneity of population also must have contributed to the low outcomes seen in non-high-dose methotrexate-based regimens. The second aspect that Aninga et al. Brought up was the 2 RCTs conducted among these 6 studies. So this was conducted by the EOI, wherein the 2-drug regimen, which is adriamycin and platinum-based regimen, was compared with a methotrexate-containing regimen. While in the first trial, it found that the 2-drug regimen was actually superior to the methotrexate-containing regimen. In the subsequent trial, they were found to be efficacious. However, their conclusions was fraught with criticism because the dose intensity of adriamycin and platinum was decreased in the methotrexate-containing arm, thereby not giving any constructive conclusions. And finally, in the Cochrane review by Van Dalen et al., also published in the same year in 2011, he declares that there is no high-quality evidence to support the use of methotrexate in osteosarcoma over other agents. And in fact, there was not a single study identified in which the only difference between the treatment groups was the use of methotrexate. So no recommendations for the use of methotrexate could be made for clinical practice. Let's look at some smaller studies. The OGS study from India is also an example of the experience advantage I was trying to talk about previously. OGS 99, when the study began in 2000, it had an event-free survival of 38%. Over the years, with improvements and innovations in the way the very same 3 drugs were delivered, and also improvements in supportive care strategies, the same study group was able to achieve an outcome of 62%. This is equivalent to the results of the Euromos trial, in which the 5-year event-free survival was 60%. And other studies with smaller numbers performed across the world with a non-high-dose methotrexate containing regimen showed extremely good outcomes between 70 to 85%. In India, however, we are yet to reach those numbers except for the OGS group. So coming to the next aspect of choosing an appropriate regimen, the feasibility of a high-dose methotrexate regimen. This regimen requires both manpower and resources, like any other protocol. However, the demands for resources is quite impressive. It requires always requires an inpatient admission for a minimum of 3 to 4 days, for which availability of beds is a resource limitation. It entails mandatory monitoring. Many of our centers do not have the facilities for PK monitoring. It requires stringent fluid management and line care, for which nursing staff numbers, again, is a requirement which many of us do not have. And toxicity management requires intensive care facilities for dialysis. In fact, glucosidase is not available in India. It requires blood product stocks. So all of these make this regimen highly resource intensive. Now, what about labor? High-dose methotrexate protocol have protocol-specific demands. For example, we need to screen for risk factors for toxicity. We need to have stringent preventive measures in place to prevent toxicity. We need to have investigations like methotrexate levels and creatinine levels to recognize delayed methotrexate clearance at specific time points. And also, in the presence of a delayed methotrexate clearance, we require drugs like glucosidase. So all of this makes the protocol-specific demands highly labor-intensive. Now let's compare the toxicities of, in comparison to this, ifosfamide probably just requires fluids and mesna. So let's come to the toxicity profile of high-dose methotrexate versus non-high-dose methotrexate. So any drug regimen has both acute and chronic toxicity. However, methotrexate has the distinction of not having any significant late toxicities. So how can we compare these two agents? Let's look at this. These are the pre-randomization results of Euromos 1 trial. And what did they find? They found that a whopping 77% had grade 4 toxicities and 15% had grade 3. So making it 92% of patients having either a grade 3 or 4 toxicity. Grade 3 or 4 neutropenia complicated 83% cycles, 59% had infection, that's about 2/3, and more than a third had grade 3 to 4 mucositis. However, the incidence of AKI and mortality was less than 1%. And what do the authors conclude? They say that while delivering intensive chemotherapy is feasible, it is also clear that the treatment burden of MAP is exceptionally high, reflected in the levels of grade 3 and 4 hematological and non-hematological toxicity. Compare this with the toxicity of non-high-dose methotrexate protocols. Just less than 56% of patients develop febrile neutropenia, and not more than 10% of patients develop mucositis. So the toxicity profile of non-high-dose methotrexate protocols is far better than that of methotrexate-containing protocols. And to complicate things further, there are some modifiable factors in the low middle income countries which make the delivery of methotrexate a question of fear. Our undernutrition rates are 60%, 30 to 50% of our children present with advanced disease. And both of these risk factors contribute to hypoalbuminemia. And hypoalbuminemia is an independent risk factor for methotrexate toxicity. I just said that when it comes to chronic toxicities, methotrexate is clear of causing any chronic toxicity. However, methotrexate can never be administered in isolation. We clearly know that multi-agent chemotherapy is standard of care. And methotrexate is often administered with cisplatinum and adriamycin. So there are going to be issues with fertility, nephrotoxicity, cardiotoxicity, and ototoxicity. And this way, it negates, so this negates any advantage of high-dose methotrexate over ifosfamide-based regimens. But the only chronic toxicity, which is unique to a non-high-dose methotrexate-based regimen, is probably the incidence of second malignancies, which is just about 1 to 2%, especially when used with etoposide. Coming to supportive care demands, the toxicities of methotrexate are significantly higher compared to the toxicities of an ifosfamide-based regimen. We just saw that. And for the management of these toxicities, especially for methotrexate-based toxicities, there are some unique supportive care requirements, such as glucopidase, and we need parenteral nutrition for the grade 4 mucositis that it causes. We need enormous blood product support and high-end antibiotics because it gets complicated by infections. Also, we need to remember that despite all the struggle, the methotrexate monitoring that we perform, it only is an indicator for nephrotoxicity and only a limited indicator of toxicities in other systems. And to make our struggle even worse, this is a table I've presented to look at the varying ways methotrexate is actually supposed to be administered with respect to treatment tumor types and treatment protocols. So methotrexate has to be admitted in different doses across protocols. The infusion durations are different. The methotrexate monitoring time points are different. The rescue protocol is different. And this variability across tumor types and across tumor protocols makes methotrexate administration a huge challenge, especially in LMICs. And finally, is it economically viable? In the paper by Jyoti Bajpai et al., which analyzed the outcomes of OGS-12 study, there are several factors that need to be factored in to which actually result in the costs that are incurred. The admission costs, the drug costs, the administration costs, investigation costs, and toxicity management costs. So when we look at all of these various factors, we realize that the costs incurred with a high-dose methotrexate regimen is close to 3.5 times that of the cost that would be incurred by a non-high-dose methotrexate-based regimen. So is high-dose methotrexate for osteosarcoma, is it really needed? When the regimen is a custom rather than a standard of care based on randomized proof of superiority, my answer to this question would be no. And the debate shall not cease unless these answers are obtained through future research. These are my references. I thank my team at St. John's, Dr. Vandana and Dr. Anand, for being excellent mentors. And thank you to all the audience for attending today's presentation. Thanks a lot.
Great. Thank you, Jyoti. That was an outstanding presentation trying to justify why methotrexate should not be used. But I think Ricky should actually give a rebuttal to that. And Ricky, I would like you to focus on 3 or 4 aspects. First, I want you to focus on the logistics. So Jyoti brought out that the logistics of doing methotrexate high dose in India is a limiting factor. What do you have to say to that in comparison to ifosfamide? Jyoti, can we close the presentation?
Yes, sir. Yes, sir. I'll do that. Sorry.
So I agree, it does need admission, and you have a bed crunched, you might be in problems because you need to admit. But I really having used high-dose methotrexate for a very long time, the toxicity profile that you're so focusing on, I don't think it's as bad at all. It's as much as you would see with ifosfamide or any of the other drugs. It's not manageable. We've never had, even one time, had to do a run for looking for glucosidase, for example. We have had creatinines go up, but they come down in a few days. It's some bilirubin going up maybe, but that also it just resolves when you stop the drug. So it's not that much in number at all. And once you get the things going, and yes, you do need to monitor your methotrexate levels, but once you get it going, it kind of, now we are using methotrexate levels with ALLs, so it's actually not much of a difference. I think logistically speaking, I don't think it's been that much of a burden.
Okay, so
and you admit people for ifosfamide as well, at least we do.
So just coming to first, just let me dissect out the logistics. So normally you said methotrexate, Jyoti, requires admission for about 4 days, or you would expect if you give 12 grams per meter squared for about 96 hours of hydration. So what is the way to give ifosfamide then?
Yeah.
So does ifosfamide not require enough bed numbers as well? So I just want to dissect out, why do you think the bed needs of high-dose methotrexate is more than ifosfamide?
So ifosfamide hydration can last for anywhere between 6 to 8 hours, after which, at least in the OJS trials, that data that was presented, a significant number of admissions requiring ifosfamide were managed on OPD basis. And not every cycle required ifosfamide. Out of the 8 cycles that were given ifosfamide, only 4 of them actually required ifosfamide. Out of the 8 cycles in the OJS 12 protocol, only 4 cycles required ifosfamide. I suppose that is the reason they found quite a few admissions being performed on daycare basis.
Yeah. So yeah, no, you're absolutely, that's a point well taken, that ifosfamide, there is probably more track record of ifosfamide being done on a daycare basis than high-dose methotrexate being done on a daycare basis. There is track record of high-dose methotrexate also being done on a daycare basis, mainly in adults, but at a much lower dose, not at 12 grams per meter squared. So especially in the hematolymphoid malignancies in the adult setting, many of them have done only daytime hydration for 12 hours and carried on oral hydration at night. And so that is which has been done, but probably the track record for ifosfamide is more in terms of doing daycare basis. So, but nevertheless, it also requires a 3 to 5 days of hydration in the daycare. So it requires daycare beds for 5 days, whereas here you need about 4 days for the high-dose methotrexate. And you are right that the minimum number of doses you need to give is 12 for high-dose methotrexate in osteosarcoma. And whereas here you would be giving 4, or there are protocols which give 6 as well. So from that point of view, yeah, the point is that if you are a very busy center and beds are going to be a problem, especially when high-dose methotrexate is a dose-intensive regimen, in the sense that if you cannot give the high-dose methotrexate weekly basis, then the outcome is probably suboptimal. So to give it on 2 consecutive weeks, the high-dose methotrexate at 12 grams and not able to deliver because of lack of beds is suboptimal. So it's probably a trade-off in that situation, that you'll go for ifosfamide in that situation rather than high-dose methotrexate. So that is point number 1. The second thing I wanted to bring up was about levels. So you highlighted about the levels. So Ricky, do you have anything to say on the levels?
So we do 1 level at 48 hours, and that has worked for us quite well. Yeah, so unless they don't clear at that point, in which case they will stay for longer. But we do monitor the creatinine earlier, but it's the urine output and the methotrexate, just 1 check at 48.
Right. So Jyoti, anything you want to add to that before I pitch in on that?
So methotrexate levels, not all institutions, at least a majority of institutions, actually outsource this particular aspect of care. And it actually burdens the treating physician, because when we outsource it, we have to adjust a lot of things, make sure there are no levels being performed on a Sunday or on public holidays. And that apart, there are already leukemias and lymphomas where we have no choice but to give high dose methotrexate. So if I can avoid at least one disorder where this is not required, I would go for it.
Okay. So just talking about the levels, yes, there are studies which have done high dose methotrexate and shown that you can get away with levels. So what is the downside of not doing levels? Other than the fact that level may be high and you may get toxicity, what does it involve? If you want to give methotrexate without levels, what does it involve?
So the risk of nephrotoxicity cannot be anticipated without the levels. And so I may not be able to change hydration and other preventive measures as per protocol.
Okay, so I think the downside of that is that people tend to give a fixed number of folinic acid doses for the leucovorin rescue. Now the thing is there a risk of over rescuing using leucovorin? So previously it was thought it didn't matter, that you actually give 12 doses of leucovorin and that would be adequate. But now there is some emerging data that actually over rescuing of a high dose methotrexate may not be actually as good as it was, or as safe as it was meant to be before. So that is one downside of it. The second thing is you require a very diligent nursing and medical team to actually do this without levels, because you have to watch the creatinine very, very carefully and monitor everything else from the pH and the input, output, etc. So if you can do that, it can be done reasonably safe if it was mandatory to give. But I do take the point that when you have an alternative which is reasonably effective, you could consider that, especially in a situation where actually the high dose methotrexate may have huge logistic issues in terms of bed. So Shruti has also brought up a point which is of course very important. So if you administer high dose methotrexate without levels and you have a significant toxicity, yes, I don't think you can stand in the court of law that you will actually do this. And this is something which in the West people would not do and not agree for it, for the same reason that there is a legal issue here of how much rescue you follow without doing levels. And if you get toxicity, which sometimes can be severe, then it actually leads to a major issue. Now, you highlighted a lot on the glucarpidase. Now, I want to know here from the audience, how many of them had to use a glucarpidase, say in the last 1 year? Is there anybody who desperately needed a glucarpidase? And what percentage of patients actually need glucarpidase? So do you know, Jyoti, what percentage need glucarpidase?
Less than 1%. It's about 0.4% of all high-dose methotrexate cycles. I did mention in the Uramos trial results that the incidence of renal failure and need for glucarpidase is less than 1%. However, the non-hematological toxicities were of concern.
So you're absolutely right. So the glucarpidase is a overhyped system, a reason for not using methotrexate, because non-availability of glucarpidase is put as a reason for not actually being able to use high-dose methotrexate. But the point we must remember is we have actually got a very good standard operating procedure for prevention of methotrexate toxicity globally. There is a very good SOP throughout for prevention of methotrexate toxicity. What happens on day one if the methotrexate level is high is you go up on the hydration first, and then subsequently you focus on the folinic acid subsequently. And that is a well understood mechanism, and it's a well derived algorithm which is there. So the standard operating procedure is excellent for actually prevention of toxicity. The problem comes only if toxicity occurs. There we don't know what to do. Exactly how good is neurotoxicity methotrexate, what is the best drug to use, what is the best way to reverse, and other toxicity which are there, which actually becomes more of a supportive care rather than actually being able to handle it well. So from that point of view, glucarpidase, I would say, in this situation, I would say that actually Ricky has got a point that glucarpidase is actually not so critical reason for us not to use high-dose methotrexate. But your point is well taken that when there are logistic issues and you have a reasonably good alternative as ifosfamide, then you could actually consider that. Now coming to the cost component. So you put $7,000 and $1,200. Do you think that really stands good today with the cost of drugs which is there? And do you really think it costs $7,000 to actually do high-dose methotrexate and only $1,200 for ifosfamide based regimen?
So it may not be the cost of just the methotrexate and the administration related issues. It's probably the cost of the toxicity management that high-dose methotrexate demands. Like for the degree of non-hematological toxicities that was just presented in the Uremos trial and compared to the non-high-dose methotrexate based regimens, it does appear that predominantly it is the toxicity management that consumes a lot of money as compared to the drug delivery alone.
So what was the non-hematological toxicity which was most critical?
Mucositis, myelosuppression leading to blood product transfusion and infections. Almost 2/3 of those patients are supposed to have had a complication of infections.
So do you think the myelosuppression is due to the high-dose methotrexate occurring?
Maybe the degree of the degree of myelosuppression when high-dose methotrexate is given along with cisplatinum and the other adriamycin. I'm not sure why the toxicity was supposed to be so high when MAP was used. So when we look at the breakdown of costs, it looked like the toxicity management sort of gave rise to that cost consumption as compared to a non-high-dose methotrexate based regimen.
So, Ricky, you want to add anything to that, or you want to discuss about the cost issue?
Yeah, well, methotrexate itself is expensive, but actually the side effects we don't have too much problems with. It's mostly after the cisplat docs that we get the febrile neutropenias, the even mucositis you might get there. So it's not so much the methotrexate component that gives you a problem, I would say. The toxicity in the MAP would be more likely to be because of the adriamycin and cisplat.
So if you're right, okay, if the methotrexate protocol for prevention of toxicity is followed well, then the need for the mucositis after the methotrexate dose should be far less. I mean, it is not as high as it is perceived to be, provided you have a very accurate way of assessing your renal function, deciding whether to give or no, and deciding to act on it. So mucositis in that situation is less. Mucositis is probably more to the cisplat dox combination rather than actually with the methotrexate itself, because the methotrexate itself, if done well, does not give as bad mucositis as it is perceived to be. It is just that when you're not able to assess the renal function well, whether not able to do the hydration and act accordingly in time, not able to provide very meticulous nursing and fluid management, that's when it occurs. If you see, the methotrexates are given 2 consecutive doses followed by cisplat dox the following week. So the reason that the regimen was designed that way is because you do not expect severe mucositis if high-dose methotrexate is done well, and you do not expect significant myelosuppression if high-dose methotrexate is given. And because the following week itself you're giving cisplat dox, and then you give a 3 weeks break, and you give a 3 weeks break after cisplat dox, because there you expect significant myelosuppression, and there you expect more mucositis to occur. So from that point of view, if it is done well, so then it is actually not so much of a problem. So I was just going to come to the drug itself. Right now, the methotrexate cost, when the original OGS 2012 regime was written and the cost calculation was done, that time the cost of methotrexate was far higher. So now the cost of methotrexate is less. Of course, the whole methotrexate overall cost, if you look at the delta between doing MAP regime versus MAI regime, probably the cost difference will be there between methotrexate and ifosfamide. But it's not 5 times as now today's world, as much as it was projected before. So it's probably much less than that, though offhand, I definitely haven't done any calculations recently, but done about 3-4 years back, the difference was definitely not 5 times as much as what it was before. So that is the other thing. Now coming to the late toxicity. So which do you think has more late toxicity? Ricky, you want to go first? And then I'll come to Jyoti.
Ifosfamide for sure.
Yes, so what is the late toxicity in ifosfamide you would expect?
So I guess the one that we would really worry about is the secondary malignancies.
Okay. Which again is probably less than 1 or 2% still, nevertheless. But yes, anything else?
Nephrotoxicity and fertility issues.
Yeah, so tubular toxicity is far higher with ifosfamide. Of course, if you do OGS 2012, the dose is probably only 4 doses, may not be so much. because you're giving at the most, 36 grams per meter squared or 40 grams per meter squared. But if you do 6 or 8 doses of ifosfamide, then the chances of having tubular toxicity as well as contributing to the gonadal toxicity is also high. So from those point of view, it is ifosfamide long-term effects are probably more than methotrexate long-term effects. The rest of it, the cisplatin and adriamycin toxicity is common between the two. So both of them do the same thing. Of course, there may be a slight increased risk of second malignancies with the ifosfamide arm compared to the methotrexate arm. So that's the other one. Now it's anybody else wants to ask any questions?
There are a couple of questions in the chat box that I can see. Maybe we can take them one by one. So
if you were to do a single methotrexate level, Vasudha has got a question. Would you do 24 level or a 48-hour level in osteosarcoma? So would you want to answer that, Ricky, and then Jyoti, if you want to tell as well? And Raghuram has put his opinion on that already.
We have been doing it at 48 hour, and that has been working well for us. We monitor urine output and general patient condition really for the rest of it, and usually we don't have any problems. Yeah, actually, I remember just one patient who we've had a little bit of a problem with. But other than that, T48 is working for us very well.
Right. So yeah, Jyoti, anything you want to add on that?
I would prefer T20. I mean, ideally we should be doing both, but T24 because at least it gives us a window where I can get away with just hydration. But by T48, I have to do hydration as well as keep increasing leucovorin doses or duration at which it is administered and keep checking methotrexate levels till it becomes 0.1.
Yeah. So yeah, so both of you are right. So it's the safest way is to start from 24-hour levels and adjust the leucovorin dose accordingly. And then continue to follow it up till it's less than 0.15 or 0.1 or 0.2, whatever different protocols would say. But if you had to do one level to decide whether to do more or no, would be the 48-hour level. So that 48-hour level would actually give you a fairly good indication of the drug levels which has come down. And if based on that, you can actually decide to a large extent how much more hydration to give, etc. So I mean, Gargi has brought up an important question. I will discuss that. So you spoke about Uromos giving an outcome and OGS 2012 also giving an outcome which was similar. Is there a difference in the population between the Uromos outcome what you put versus OGS 2012, the outcome which you put? What is the difference between those two studies, the OGS 2012 and the Uromos study?
So India outcomes as compared to the Western counterparts.
Okay. I'm more talking about the study itself. What is the population in those two?
Yeah, it's a massive number. It's a massive number. It is the number of patients used in the Uromos trial is close to 2,000 or even more. And the number in the OGS 12 is significantly lesser. And the population it includes populations across continents. There is a representation of the geographic heterogeneity of the disease, whereas OGS 12 is predominantly based in India. So it is not representative of the world at large.
Right. So you're right from that point of view. Ricky, you want to add anything about the OGS 2012 paper? So here I am questioning our own data, so that is fine, but it is important to bring that discussion up. Why is the TMH data and the Uromos data? Is there any difference in the population? Is there any difference in the studies itself? In the overall design of the study? Is there any difference in those two? So Gargi, Ricky, yeah, go ahead. Sorry, you're muted. Ricky, go ahead.
Uromos is an RCT. OGS 12 is a single arm study. Okay. That's another difference.
Yes, you're right. And what type of study was the OGS 2012? I think a lot of people have put their choices in the chat box. So somebody has written, yes, OGS 2012 was a retrospective study, which is correct. So it was a retrospective analysis of the departmental database which was maintained. which means that comes with an inherent bias of only having treated children or patients, children and adults both, who have been within the hospital and taken treatment with us. So it doesn't take into account people who dropped out in the beginning, people who are metastatic disease, but operated were not included in that. So the EuroMOS is one, it's a prospective database, which always has a better data collection, though it's a randomized trial. You forget the randomization part. Even if we did a single, looked at only the MAP regimen, it's a prospectively meant data. It included all localized disease and operated metastatic disease. So now the operated metastatic disease, do they behave samely as a localized disease? So do the operated metastatic disease of osteosarcoma have the same outcome as a non-metastatic disease?
No, they don't.
Yeah.
But
so what would be the outcome in a metastatic disease, which is completely all the metastases have been removed and treated on the, say, any regimen? What would be the difference in outcome between them and the non-metastatic disease?
So there are three aspects here. There is a metastatic disease where the resection status is incomplete. There's a metastatic disease with complete resection. And there's a non-metastatic.
Complete resection disease.
So there's a close to 20-30% difference in survival in these two groups.
Correct. So the OGS, the EuroMOS includes all non-metastatic disease, but also includes all metastatic disease which are operated. So there is already something pulling down the outcome of EuroMOS, whereas the OGS 2012 is only non-metastatic disease, which you have presented. And the metastatic disease outcome is presented separately in another paper, which is far, far less. So from that point of view, we are not actually comparing apples with apples. We are actually comparing two different data points, two different data sets, two different way of doing it. From those point of view, it is actually not comparable, although it gives you an indication that in India, if you are able to treat non-metastatic osteosarcoma completely, finish the treatment with this regime, you do get a reasonably good outcome. But that does not reflect the whole population outcome of the children or patients who actually come to the hospital. Whereas the EuroMOS reflects more of the population who actually were treated with a curative intent, which is completely resected, as well as those who underwent and who are localized disease. So what is the outcome of, so there are two papers which have come out from our own institute on this, and the metastatic disease operable outcome is less than 20%. So that outcome is really not so good at all, even though they were operated. So from those point of view, it is probably not as good as we think, because that we are the data how we are done, but that's what the whole thing is about. Now we'll go through the other questions. So Preetham, I lost track on the number of questions. Can you go ahead and ask?
Sure, sir. So I can see a question from Dr. Jitin. What is the current recommended doses for IAP regimen, and is there any data to support it other than OGS drugs?
So you want to answer that, Jyoti? What is the dose?
Sorry, I didn't.
What is the dose for ifosfamide, doxorubicin, and cisplatin regime? The IAP or OGS 2000.
Yeah, so
what is the recommended dose? What is the recommended dose of ifosfamide and doxorubicin mainly? I think cisplatin is less controversial.
Cisplatin is standard 100 to 120 mg per meter square. Ifosfamide is 9 to 12 grams per meter square. The OGS uses 9 grams, and some other protocols go up to 12 grams per meter square. And doxorubicin is 75 mg per meter square. That's 25, 25, 25 over 3 days.
Yeah. So, okay. Anybody else wants to add anything more to that? So the doxorubicin recommended for osteosarcoma is actually much higher than what we are actually giving. So our original OGS protocol actually included 90 milligrams of doxorubicin rather than 75 milligrams of doxorubicin, but we felt toxicity was a bit higher there. But if you look at the MAP regimen, the doxorubicin is how much there? In the MAP regimen.
I think the cumulative doxorubicin is higher than the cumulative doxorubicin in the IAP protocol.
That's right. It's more than 400 milligrams per
yeah,
meter squared of doxorubicin.
150. It's 300 mg cumulative dose in IAP versus 400, 50. Close to 400. Yeah, 450 in MAP. Right.
Yeah. So probably 450 is too much to give in an Indian setting. And I don't know if Maya is here and she can comment on that. So what about I mean, it's 450 milligram. What would be the toxicity in an Indian setting, and especially in the context of what was seen in the Euromos trial? So that's probably too much, 450 milligram per meter squared. But even 300 milligram per meter squared is probably a bit lower as well, which is going, but that seems to be tolerated reasonably well, and we are continuing to do that. But otherwise, the dose recommended is probably about 360 milligram is what would be ideal to give, rather than just give only 300 milligram. But in our population, when this trial was originally done, it was 8-10 years back when it was originally designed. It was felt that malnutrition was more. It was treated more in adults and children combined. Adults were not tolerating well, so that data got extrapolated to children as well. Probably you could have given up to 360 milligram per meter squared, but we actually kept it to 300. And since we're getting a reasonable outcome, probably not perfect outcome, reasonable outcome, we have left it at that. Maya, are you there? Anybody else would like to comment on the dose of 450 milligram per meter squared and what it actually means? What is the toxicity seen in Euromos?
Yeah, 450 milligram, it causes a reasonable amount of cardiotoxicity as compared to 300 mg.
Yeah. So, okay, so that's the other question. Any other questions which are there?
There's one question that in the context of the metastatic disease, many a times the pulmonary meds are actually not resectable. Then which chemotherapy regimen should one prefer for such patients in resource-limited setting?
I think that's an excellent question. So I would like both Ricky and Jyoti to go first.
So, in a setting with pulmonary metastasis which are not resectable, technically we are dealing with a palliative care scenario. In our setting, I think I would push for palliative care because our outcomes with metastatic non-resectable pulmonary disease is 0%.
Okay. So, but if you had to give a chemotherapy, would you have a choice? Which one you would like to give between the two drugs you both debated on?
I would still stick with ifosfamide because a child with pulmonary metastasis, advanced stage, has a lot of comorbidity. I mean, they will be suffering with undernutrition and many other problems which will complicate giving high-dose methotrexate. And the outcomes are maybe 10-20% different with ifosfamide and methotrexate.
Which is better?
Yes, it is. Compared to 0, it is definitely better.
Which one? Which is better? Sorry.
High-dose methotrexate-based regimens have close to 30-40% survival as compared to 20% and less for an ifosfamide-based regimen in metastatic disease.
In metastatic setting, fully resected ones. Yeah?
Yes, sir.
Okay. So, yeah. So, Ricky, anything you want to add?
If it is not resectable, then in our case, we probably, I agree with Jyoti, we probably have to think in terms of it being palliative.
So I agree with the first statement both of you did, that if it is large metastasis, more than 1 centimeter, and if they are multiple and they are not resectable, either because they are in the pleura with hemorrhagic effusion, or they are hilar nodes, or they are multiple, they're bilateral, which are more than 4 or 5, and if the surgeons feel they are unresectable, then it is actually very difficult to actually cure an osteosarcoma. However, if there are doubtful metastases, there are multiple which are, say, or a few which are less than 1 centimeter, and you had only 1 or 2 which were more than 1 centimeter, then it's probably worth giving a trial of treatment, chemotherapy, and see what happens to those. If those tiny nodules disappear, which may or may not be metastasis, and these 1 or 2 nodules only remain, then in that situation, it's worth going and doing a metastectomy, and these other nodules have disappeared, with the whole idea being that you would actually still get only a 20% outcome in that situation. But if there are multiple large, more than 1 centimeter mets, if some of them are already calcified, then the chances of cure, I agree with both of you, is extremely poor. But if you ask from whatever data is available, you're right, Jyoti, that methotrexate tends to have a better outcome in lung metastatic disease compared to a non-lung metastatic disease. So methotrexate seems to be, if between methotrexate and ifosfamide, with lung metastasis, methotrexate seems to have a better outcome when it is completely resected. And again, there will be no head-to-head comparison, but this is what you would actually see, whether methotrexate would actually provide this slight advantage over ifosfamide in completely resected lung metastasis. So that's one. Then the next question was, so if gemcitabine based chemo, if ifosfamide, if they have not received it IE, should we give it or no? Do either of you have any answer on that?
So gemcitabine has been studied in relapsed protocols. I'm not aware of any gemcitabine-based protocol upfront used in upfront osteosarcoma.
Yeah, Ricky?
In upfront, it doesn't have as much efficacy at all. It's not as good as what the 4 drugs that we've been discussing. It has been used with like some response in relapse cases. Yeah.
So
I have
both of you,
actually
right?
used it once with methotrexate.
So there are phase 2 and some phase 2 studies on using gemcitabine in relapsed osteosarcomas, and the outcome has not been great. So I think it is still not come into any frontline therapy to actually use high dose methotrexate. I mean, to use gemcitabine at all in a osteosarcoma. So the first question is, should we actually give any chemotherapy for relapse? That itself is a question which needs to be answered. And that itself, we do not know the answer, but generally plan A, plan B, plan C is all to do surgery, surgery, surgery. And chemotherapy in a relapse setting probably has a very limited role. The other thing to remember is why these mets are so critical. And when we talk about number of mets, etc., it's not that it is about the 4 or 5 mets. It's just that the number of mets which are not seen on radiology are far higher than what we actually see on radiology. And so if you see 4 or 5, then the probability of seeing multiple mets bilaterally are much higher. That's why that 4 cutoff is considered that is a crude indicator that there are multiple mets there. So it used to be told, if you see a cockroach in your house, then there are likely multiple cockroaches in the house. So if you see a lung met on a CT scan, there are probably multiple hiding there as well. So till recently in Germany, you would actually do a thoracotomy to actually decide whether there was actually lung mets or no. So if I had lung mets only on one side, they would actually open up the opposite side first, feel manually, and if they did not find any nodules, only go back and do a metastectomy on the other side. So the idea was that you always saw more, etc. But presently it's being argued with more and more better CT scans that is probably not required. And especially with the HR CT scan, which takes very few cuts, is probably not required. So Vinay has got a question. Is there data to show methotrexate improved histological response as compared to ifosfamide based? Your take on that, both of you.
There is no head-to-head comparison, but if you look, there's definitely no head-to-head comparison on which agent induces more histological response. But when we look at trials performed in the past, methotrexate-based regimens are associated with better histological responses than ifosfamide-based regimens, and they are supposed to translate into better outcomes.
So what's the histological response you would expect in a non-metastatic osteosarcoma?
More than 90% necrosis.
No. What is the proportion who would have more than 90% necrosis?
More than 65% in a MAP-based regimen.
Yeah. And what is the published outcome in the ifosfamide outcome?
I think it was among the various regimens based on ifosfamide, it ranged anywhere between 34% to 50%.
Yeah, it's about 50% with the ifosfamide regimen, and probably methotrexate gives a slightly higher necrosis as well. And that is definitely been noted in a non-metastatic case that it would probably translate to a slightly better outcome. One of the questions which Virendra Patil has put, and also Prashant had also put, in case of poor histological response post-surgery, do you recommend shifting from one protocol to another? That means you're given MAP. If there is poor histological response, do you want to shift to ifosfamide based?
So this has been extensively studied right from, I think, the T10 protocol onwards. There have been many studies which try to assess if a switch in protocol makes a difference, but unfortunately it doesn't.
Right. Ricky, anything you want to add on that?
No, it doesn't help, and that's shown.
Anybody else wants to comment from the audience? You can unmute and say what do you think about shifting from MAP to OGS 2012 like regime.
I think definitely adding ifosfamide and etoposide has not shown to be useful if you're already used MAP. But I think the other way around is what we don't know the answer. If somebody has used cisplat, dox, and ifosfamide and there is a poor response, is there a benefit of changing over to the Euromus protocol? That I don't think there are any studies, but intuitively, I think that's what we would do.
So I agree with you, Raghuram, that shifting from MAP to ifosfamide based, I think has been proven as no value because you're adding the other drugs in the Euromas, and that did not actually show any benefit of doing that. But what we don't know is if we shift from ifosfamide to high dose methotrexate post surgery, whether it makes a difference, and that is a question which we won't know, and whether we need to answer that, which Virendra has asked IAP to MAP, we do not know the answer to that. However, what has been shown, I think, in Sameer's study from AIMS, that if you do use a two-drug induction by any chance, cisplatin dox, and if you do have a poor histological necrosis, adding the next two drugs, which was ifosfamide and etoposide, I think, which is what he added, and showed that the outcome was as good as good histological response with two drugs. So that is one situation where I think in our setting, if by any chance anybody has used cisplatin dox and the patient has come to you at surgery and you find poor necrosis, then definitely you should intensify the therapy post. But having said that, I think the time for giving two-drug regime upfront is gone. And I don't think any one of us should advocate for that, and anybody should do that. And especially in India, most hospitals are able to do either the MAP or IAP. And I think there's no reason for us not to do the three-drug regimen at all. So the other question which is there higher up, I saw someone was speaking, Manas wanted to go on dextrosoxane. Any comments on that, both of you?
It is supposed to be cardioprotective, but I have no experience with dextrosoxane, so.
It's not available, so.
Yeah, Ricky, anybody else wants to comment on dextrosoxane? Is there any risk of giving dextrosoxane?
Not that I'm aware of.
So dextrosoxane in some of, yeah, go ahead, Anand. You wanted to say something?
I think in the germ cell tumor, some paper, sorry, I don't remember the exact values, that there was some decreased outcome when in the arm with dextrosoxane.
In germ cell tumor, I mean, they use doxorubicin.
Sorry.
No, you're right. So there are some data, including there was a doubt raised in osteosarcoma itself, whether actually adding dextrosoxane is actually giving a worse outcome, or rather some suboptimal outcome. But generally, we do not have any data other than dextrosoxane in osteosarcoma to tell that it actually protects in this situation or no. So for that reason, it's routinely not recommended unless early cardiotoxicity has been picked up. In that situation, you definitely can give dextrosoxane, provided your fractional shortening is more than 26%, but it has dropped below 30%. So in that situation, you can give a dextrosoxane and give a short infusion of doxorubicin. Otherwise, it's not indicated dextrosoxane to use as a prophylactic measure, especially in osteosarcoma. However, in children, it has been given in, as you know, in hepatoblastoma, etc., where when the dextrosoxane was given to the very young children, in that, again, we do not know the long-term effect of whether it has actually done cardiac protection, but it's routinely not recommended at all in osteosarcoma. The other question which was there was cisplatin versus carboplatin. Any take on that? Prashant's question.
So very few trials have actually used carboplatin in the place of cisplatin, especially the Brazil studies that I just put up on my slides. And there was some criticism to it as to why carboplatin was used when cisplatin is known to have a good efficacy.
Ricky, anything?
There have been studies which say that carboplatin is not as efficacious. The response rate is not as good.
So, Prashant, we don't know the answer to that question, including St. Jude's have used carboplatin for a long period of time, and I got reasonably good outcomes with that. Obviously, the toxicity is not, much less with carboplatin in terms of ototoxicity and nephrotoxicity, but generally it is not considered as a standard of care globally. So for that reason, I think everybody sticks to cisplatin. There's no other reason for doing that. Having said that, if you get ototoxicity significantly, you could replace cisplatin with carboplatin. And then in that situation, if your ototoxicity is the drop of 40 decibels is about 2000 hertz, but not less than 2000 hertz, in that situation, you could use carboplatin if it has occurred very early in the period. Otherwise, not required. But of course, the mylotoxicity will be significant.
Yeah, that was...
If you use carbo and dox, will be significant. But you've done that in hepatoblastoma, for example, and we are doing that in the supraplato. So it is being done. But yes, but it causes significant mylotoxicity.
It even delays timely administration of subsequent cycles.
Yeah. So that's all about it. I know, Prashant. Actually, I will also need to look at the data a bit more on what exactly is the problem with carboplatin. But if anybody else want to add on to it, can definitely go ahead. Any other questions?
So can we take the last question, sir? So that's kind of the probably will be extract of this today's seminar. That can we reach a consensus after today's discussion that a center which has access to methotrexate therapeutic drug monitoring will do methotrexate and the others will stick to non-methotrexate protocol? Is that consensus that we can reach today?
So what do you think, both of you, the debating people? So let's say center has got adequate infrastructure to do high-dose methotrexate in terms of beds, etc., levels, all the things which we mentioned are logistics issues. Should we do high-dose methotrexate or do ifosfamide?
I would first do an RCT.
But to answer that RCT, I think will take 10 years probably. Some of us would have retired and not even be debating this. But yeah.
So if logistics is not a problem, that's probably the greatest limiting factor for administration of methotrexate-based regimens. If logistics is not a problem, I think most of the problem is solved.
What about Ricky? Ricky, are you there?
What's the question? Sorry.
The question was that if logistics were not an issue, would you recommend high-dose methotrexate should be the first option?
Yes, I think so. It's
Okay.
got more, definitely more data behind it.
So I think both of you are right. So Rhythm, we fully agree that if logistics is not an issue, then for that additional maybe 5 or 10% benefit, you could use high-dose methotrexate based regimen. However, please watch for the cardiotoxicity. I think that is something which we have not discussed too much today. With 450 milligram per meter squared of MAP, the cardiotoxicity in India would be definitely far higher than what you would see within IAP regimen. So that if you can watch very carefully and do that, then yes, high-dose methotrexate based regimen has the best track record, and that's what you should do. And that's what many hospitals in India would do if logistics was not an issue, and rightfully so. If logistics is an issue, then IAP is not a bad plan B. It is a very close plan B. And very close plan B is exactly for the reason that traditionally people have used high-dose methotrexate, and we really do not know whether ifosfamide will be really inferior to methotrexate or equal to methotrexate, and it may be equal. So from that point of view, I think you agree that logistics is not an issue. Please do MAP. If logistics is an issue, you could consider this, and it's definitely not something which you have to worry about if you're using ifosfamide.
Thank you so much, sir. This was, I think, one of the most educative sessions we ever had in this platform. We thank both the speaker, Dr. Ricky, and moderator, Dr. Girish, for their inputs. I will just beg one more minute as I announce the next session for October.
So
in October, we discuss on childhood chronic ITP.
So, Pritham, just before I just want to bring in an issue which I put up in the WhatsApp group, and I just want all of you know before people start exiting out.
Yes, sir.
So the methotrexate high dose from Intas, which I put the level in, has got infection at the moment and has had significant infection with Pseudomonas. And that's why that letter had come out from Intas, which I put in the WhatsApp group, telling that to withdraw the batches. But what they have not acted is fast enough. And today we had a meeting with the top people with Intas today at Tata Memorial Hospital. And we have told them from today, all the batches of Merex, where we have grown infection, should be pulled out of all hospitals immediately. Unfortunately, there are many Pseudomonas infections reported across the country, And even the vials which have been opened have got unopened vials when cultured also got Pseudomonas. So Merex 1 gram, definitely I would recommend that if you are going to use it, at least from the batch 1 or 2, you please test in the microbiology. 500 milligram also today we were brought to the notice that 1 or 2 also grew Pseudomonas, unopened ones. But the batches which have been sent by Inters, which I put in the WhatsApp group, definitely should be withdrawn even without testing. And anything else you want to use Merex, then please test. And that has been noticed only with them. And it's not that they're not a good company. They're a very good company. There is a problem which has occurred, and it has been highlighted to them to actually pull back immediately. And that's what I would like to highlight all of you. I put it in the group, but because we are discussing methotrexate, I think it is critical that all of you do not give Merex 1 gram till clarity comes on this, which should come in the next few days.
Thank you so much, sir. I was just announcing the next session will be on chronic ITP in October, and the case presentation will be from Vijayawariya Hospital. Sangeeta Mudaliar will discuss on the diagnostic and clinical evaluation part, and the management overview will be discussed by Dr. Manas Kalra from Gangaram Hospital, New Delhi. The date would be 12th of October at 7 p.m. Thank you so much. Good night.
Thank
Great.
you, everyone.
Good night. Good night all. Thank you.